much for the kind introduction. I'm very proud and very happy to be with you today and to address this important topic, the clinical significance of what we heard in the morning in the framework of perioperative fluid therapy. As you can see here, I changed my job a few weeks ago. I'm now head of the department of the St. Elizabeth Hospital in Straubing, still being part of the medical faculty certainly, but one day beyond clinical and scientific work, one day also clinicians should work a little bit. That's what I'm doing currently. So I was very impressed in the morning by the last two lectures I heard, all the sophisticated insight into the microcirculation, into the view to the endothelial glycocalyx. To the physiologists in here, I will tell you now what we clinicians make out of that. To the clinicians, I will give you my ideas on how to handle fluids, crystalloids, and colloids, and why this is important in the framework of the endothelial glycocalyx. I will start with a clinical example, the original case of a 36-year-old female patient who underwent 12 years ago in my former hospital, Klinikum Großharden in Munich, a major abdominal surgical intervention, and to receive by the anesthesiologist the traditional, the liberal, the crystalloid-based fluid approach. We combined this and many other cases in this time with direct assessment, direct measurement of the blood volume using a very reliable double tracer method at the beginning and at the end of the surgical intervention for scientific reasons. And you can see already here in this slide that if it was the target to maintain the quantitative component of cardiac preload, the blood volume, then obviously this target was reached also in former times using the so-called crystalloid-based traditional approach, how we call it in Germany, in part. What happened intraoperatively? Why came this result up? Well, relatively moderate losses on the output side, blood losses and urinary output, were answered aggressively by a few colloids, but a massive amount of crystalloids. But this tremendous excess on the input side of our sensible perioperative balance did not expand blood volume. Blood volume remained at the preoperative level, which simply means nothing more and nothing less that at the end of the day we were missing 4 liters of fluid in our perioperative balance. We infused it intravenously in excess, but we couldn't find it at the end of the surgery in that place where we infused it to. And the simple message I will answer in the following 45 minutes is, where has this fluid disappeared to and why did this fluid do that? First of all, a few physiological considerations once again, but from a more quantitative side, coming not very sophisticated from the insides, but looking on things from outside. You all know the compartment system of the human body. You know that 60% of the total body mass of the cardiopulmonary healthy adult is water, stored mainly intracellularly. Only 1/3 of the total body water is extracellularly, and here mainly by 4/5 interstitially. Only 1/5 contributes as 3 liters of plasma, around roughly 3 liters of plasma, together with 2 liters of red cells, as 5 liters of blood volume as the quantitative component to cardiac preload. And also quantitatively, to remain the compartments as obviously intended by nature, there are mainly two barriers. The cellular membrane, very fragile, but quantitatively completely impermeable for all major kinds of solutes, in contrast to the vascular barrier. The vascular barrier is able to deal with hydrostatic gradients. This is an important part of its job because blood does only then move, as you all know, from the left ventricle across the microcirculation back to the right heart. If it is forced to do that by a hydrostatic gradient, and this pressurization of the vasculature in the high pressure segments by the external work of the left ventricle does not only move the blood column forward, but by trend it also tries to move plasma constituents outwards across the vascular barrier towards the interstitial space. And this is prevented as long as the barrier works properly, also at least quantitatively. In some, it allows free and easy exchange with or without reabsorption. This doesn't matter in this context of small solutes, but it sufficiently retains large molecules like proteins together with the accompanying water load. How does this work? And you also got in the morning the difference between the traditional and the revised Starling principle. I also like the model of Mr. Adamson very, very much, but traditionally, more than 100 years ago, Starling schematically opposed this inwardly directed oncotic gradient to the outwards directed hydrostatic force. Meanwhile, we know this doesn't work exactly like this, because we know there is a a high interstitial protein concentration. This does not work. We have additionally a small, at first sight, insignificant structure obviously attached to the endothelial surface, and this is the endothelial glycocalyx we heard about in the morning. How can we find it? Go with the blood flow towards the microcirculation. It's attached there, most likely across the whole vascular endothelium of the most mammals. Here is a picture from my group, a very close look to the anatomical vessel wall of the coronary system of a guinea pig. Here's the endothelial cell line. The microvessel would continue like this. Here is the distribution space of the blood cells, and here, stained in black with also our fixative containing lanthanum, the glycocalyx here with a thickness of 300 to 400 nanometers. It consists of membrane-bound proteoglycans carrying negatively charged side chains, and these charges do count for the biophysicochemical properties leading to an active binding of plasma constituents in vivo, forming the endothelial surface layer. So the glycocalyx is only a skeleton of what is active in vivo when the glycocalyx gets in touch with the plasma. This non-circulating part of the plasma volume amounts in cardiopulmonary healthy adults up to 1 liter. It has a thickness between 1 and 2 micrometers, and so the glycocalyx functionally divides the plasma volume into a circulating part, being the distribution space of the blood cells, and the non-circulating jail phase, intravascular jail phase, as we heard before, attached to the endothelial surface, to the endothelial glycocalyx. Please keep this picture in mind. We need it later on for methodological aspects of blood volume measurements. It became very early evident during the last 10 years that such a significant prominent structure at the endothelial surface should significantly contribute to vascular barrier competence. I told you before, I also like the picture of Mr. Adams very, very much. He's schematically, he said that plasma constituents are driven outwards, retained within the endothelial glycocalyx, but leaving a small space beneath the glycocalyx free of protein, and only a small rest flux leads the rest of the proteins, which might be here, towards the interstitial space, and leading them back via the lymphatic system towards the circulation. What is the importance for clinicians of this knowledge so far? It's very important to understand that for a properly working vascular barrier, you need an intact endothelial glycocalyx and a suitable minimal concentration of suitable plasma proteins. But as you mentioned before, it was also my group who showed this. Most likely 1 gram% of albumin might be sufficient, at least in an experimental model, to make this system work. So normally no need to infuse albumin for this reason. And it's also very important to understand that many NOXers, the OR and the ICU patients come frequently across with in our daily clinical practice, might be able to destroy the glycocalyx, this important part of vascular barrier functioning, immediately. For example, ischemia and reperfusion injury and inflammation, not only due to bacterial invasion, but also due to surgical impact. And beyond that, also hypervolemia is an important NOXer which destroys the glycocalyx immediately, most likely due to the release of atrial natriuretic peptide, which might be able, we don't know exactly, to activate metalloproteinases, which digest the glycocalyx within a very short period of time. So it's very important to grasp the message. The endothelial surface layer is a decisive part of vascular barrier functioning, and sepsis, surgery, and fluid therapy, also hyperglycemia, might be able to alter it significantly. And this directly leads to the impact of this knowledge on fluid handling. Once again, what is the target when clinicians are handling crystalloids and colloids? Normally, we are targeting at normal volemia of as many compartments as long as possible, presuming that this might be a good idea. We do not know exactly from outcome-based evidence, but we think that might be the best for the patient. So the indication for volume replacement therapy beyond a basal maintenance rate, so volume replacement therapy addressing explicitly cardiac preload, is intravascular hypovolemia. So our command variable, at least theoretical, when doing volume replacement therapy, is the blood volume. This is a very problematic command variable because in the clinical setting we are not able normally to directly assess blood volume. And it is very problematic that also our surrogates frequently leave us out in the rain. You cannot rely on blood pressure, you cannot rely on heart rate. CVP also is a problem. Many groups showed this before, and this was also illustrated by our group 2 years ago in this critical care paper. Here is the initial blood volume of close to 4 liters. We reduced it by more than 10% towards 3.5 liters and restored it afterwards. And what we observed was you see nothing in blood pressure, no significant change in heart rate, and no significant change or clinically relevant change in the CVP. So if you're not able to do extended monitoring, assessing flow-related variables, and in our hospitals, also in the university, at most working places, we didn't have the possibility to do measurements like that. So we are left out in the rain, and this is also reflected in the management of hypervolemia in most of the large randomized trials which were published during the last years. So patients without knowledge of volume effects and without extended monitoring are endangered to suffer from acute hypovolemia, and Michael Pinsky frequently showed and stated that such an acute hypovolemia might be a problem. It significantly reduces local tissue perfusion by well-known compensatory mechanisms, and already a deficit of 10% versus normal, as seen in this example before, significantly compromises splanchnic perfusion. So what do we need? Do we need, if we are not able to directly measure blood volume and to assess flow-related variables, we need to know the central pharmacokinetic property of those drugs we are using to maintain cardiac preload in the context of massive acute bleeding. And this central property is called the volume effect. It is that part of the infused amount of a crystalloid or a colloid working properly, contributing within the circulation to cardiac preload, not being directly shifted or excreted by a renal first pass effect. What I showed you before, and what you all know certainly, is that clinical volume effects, your impression, blood pressure, heart rate, is very often misleading. We need measured volume effects. And looking into literature suggests that it is no problem to get the measured volume effects. There are hundreds of volume effects on all various preparations. Obviously, you should only look into literature. Also, Robert Hahn contributed significantly here. But unfortunately, most, 98% of these volume effects do suffer from one severe methodological problem, which is caused by the existence of the endothelial surface layer. And this problem is called the hematocrit dilution. Robert's kinetic studies, for example, are done with hematocrit dilution. It's not too bad, but we must know the limitations to understand properly what he actually showed and what investigators using this technique were not able to actually show. What is the principle of hematocrit dilution? Well, they are normally estimating blood volume with the help of the body surface area and measuring initial hematocrit. Say you have a patient where you're estimating 5 liters of blood volume. The hematocrit should be 0.4, so 5 times 0.4 leads to a calculated red cell volume of 2 liters, and the rest of the blood volume is plasma. Then you are infusing something, for example, 1 liter of colloid, and you are reassessing hematocrit, which is now, say, 0.35. Then these investigators use these few numbers by a simple rule of 3 to calculate the apparent new plasma volume. Here's your hematocrit sample, the new one. These 0.35 are still representing, after just infusing something, the 2 liters of red cells. The 0.65 are representing the apparent new plasma volume. So this is the simple rule of 3 you all know from maths in school, leading to an apparent new plasma volume after this hematocrit dilution of 3.7. So theoretically, applying this technique to this measurement means the infusion of 1 liter of colloid increased plasma from 3 to 3.5 liters, that is by 700 ml per 1000 ml. So this is a calculated volume effect of 70%. Excellent, in principle. But the problem is that our patients are no hematocrit tubes. There is an important structure beyond I and others introduced to you before. It's the glycocalyx, and the problem is the different distribution space of the cells and the plasma volume. And this is a severe methodological problem in the context of a measure where you're infusing something. I told you hypervolemia should theoretically be able to destroy the endothelial surface layer, to reduce its total volume. And we were also able to measure this in human patients using a tracer method. Here is the total volume of the endothelial surface layer before and after the intravenous infusion of 1.4 liters of an iso-oncotic colloid. From 700 ml, it went down, it broke down to 1/3 of the initial value. And what might be a biological catastrophe occurring at the endothelial surface is also a severe methodological problem to hematocrit dilution. Why is this a problem? You're always sampling from the circulating part of your blood. So if you're doing something which reduces the total volume of this jail phase, this increases the distribution space of your red cells. And so a decrease of the hematocrit from 0.4 to 0.35 might be explained totally, completely by this effect. It must not inevitably have anything to do with the true volume effect. So this is the problem of hematocrit dilution, which is an excellent methodology because it's simple. But the problem you have to grasp before discussing the effects is it overestimates systematically the volume effects. You can derive valid data on volume effects only by direct measurement of plasma and red cell volume in the individual measuring point. So the first message of the impact of the glycocalyx on fluid handling is do not trust in volume effects and related conclusions derived from hematocrit dilution. So what we need are true volume effects to be able to work with our patients, a patient who is bleeding, if we are not able to do extended monitoring, which is at least in Germany still the case in most of our patients. But what you also need, beyond an adequate methodology, is a suitable model. It's not suitable to talk about the volume effect if you have a patient who is not in need of volume because volume preparations are drugs and they need an indication. And the indication for volume replacement is a volume deficit. So you need a bleeding patient where you are substituting the lost blood in order to maintain the quantitative component of cardiac preload. This is what we did. We combined in perioperative patients coming from steady state an acute normovolemic hemodilution indicated as a blood-saving preoperative measure. We combined it with 2 time points measuring blood volume directly using a double tracer method, measuring plasma volume using the indocyanine green dilution technique, and measuring red cell volume using autologous red cells labeled with sodium fluorescein. The first volume effect is that of an isotonic crystalloid. We chose Ringer's lactate. You know it's slightly hypotonic, but unfortunately it's nevertheless one of the 2 most frequently infused preparations next to isotonic saline worldwide, crystalloidal preparations. An acute normovolemic hemodilution in 10 healthy preoperative patients. Over 30 minutes, we withdrew 1.1 liters of blood and simultaneously infused the 3-fold amount of Ringer's lactate. So following the theory that a patient, you hear this theory very often on international and national meetings, a bleeding patient who is in need of volume is able to retain the crystalloids much better. So we choose to infuse the 3-fold amount of the crystalloid in order to maintain blood volume despite this acute bleeding. And what we observed was a severe breakdown of blood volume, nevertheless, from 4 to 3.5 liters by more than 10%. So the actual volume effect of Ringer's lactate in these bleeding patients, despite they would have been actually in need of volume, was poor, around 20%. It's slightly hypotonic. This might explain why it was 17%. So exactly what traditional physiology would have suggested, because the target compartment of a crystalloid should theoretically be the whole extracellular space, and this is by only 20% the intravascular one. This is what we measured in human patients. The next volume effect, that of an iso-oncotic colloid, just an example, it also works with albumin, 6% hydroxyethyl starch. The same model in a comparable collective. We withdrew 1.4 liters of blood over 40 minutes and simultaneously infused, triggered by the hematocrit, 1.7 liters of colloid. What you observed was a stabilization of blood volume from 1.1 to 4.1 liters to 4.3 liters, leading to a volume effect of around 100%. And this volume effect was stable at least for the first 2 hours. We didn't perform any measurements beyond. Very interesting in this context, Hematocrit dilution would have led in the same patients to a volume effect of 130%, because also this adequate infusion in context of bleeding led to a slight reduction of the total volume of the endothelial surface layer. So this would have led to the wrong volume effect. The correct, unquestioned volume effect assessed in human patients by a reliable methodology was at the expected 100%. And this also works with human albumin, slightly lower, between 80 and 100%. And once again, exactly what traditional physiology would have predicted for a properly working vascular barrier, because such a barrier should be able to retain large molecules like albumin, but also theoretically, hopefully, like the artificial substitutes. But we have to be careful, and this is once again the point where the glycocalyx comes back into our considerations. It would be the wrong conclusion to say that the volume effect of an iso-oncotic colloid is, in contrast to the crystalloid, close to 100%. It is absolutely related to the correct indication of this colloid. If you try to preemptively expand blood volume in human patients by an infusion of a colloid beyond what the patient would call for himself normal, if you try to do hypervolemic hemodilution, then you will be severely disappointed. This was also measured more than 12 years ago in human patients. Once again, an iso-oncotic colloidal preparation, but volume loading in a comparable collective. No blood loss, but additionally to the blood volume the patient comes with to us in steady state, an infusion of 1.4 liters of 5% human albumin. This expanded somewhat blood volume from 4.2 to 4.7 liters, but this is by far not at the extent of the infused amount. The volume effect of this preparation, which shows with a proper indication in the hypovolemic patient, a volume effect of 80 to 100%, severely breaks down towards 40% if it's not indicated, if the patient is previously normovolemic. And this was also confirmed by measurements for hydroxyethyl starch. Once again, a preparation which shows a volume effect in the hypovolemic patient of close to 100%. It breaks down here to around 40% if it's given without a proper indication in the non-hypovolemic patient. Once again, the overview I showed you before, crystalloids in the bleeding patient do not work in that way we hope for in a human patient in the hospital, at least as I hope. And if you're choosing a colloid, then they work only if they are indicated. If the patient is bleeding, then the volume effect is between 80 and 100%. If it's not indicated, then there is a large scatter and the mean volume effect is around 40%. So obviously, not indicated colloids directly shift by 60% towards the interstitial space, and we have good indications from literature and also from our own work that it destroys on that way an important part of the vascular barrier, the endothelial glycocalyx and the endothelial surface layer. I showed you this slide before. This is the result from the same patients in the context of hypervolemia. The total volume of the surface layer breaks down towards 1/3 of the initial value. So what is the second message out of the clinical impact of the glycocalyx on fluid handling? The second message is that volume effects of colloids especially are context sensitive. They only work if you are targeting at normovolemia, then they only work if they are indicated, if the patient is hypovolemic, if the patient is in need of volume, if this drug is indicated. And the second important message in this context is that there are two completely different pathophysiologies of perioperative fluid shifting. We term these two types of shifting in 2008 type 1 and type 2. From my point of view, decidedly not taking any recirculation phenomena into consideration now, but the initial effect, then we can say that the type 1 shifting is not a pathophysiological surprise. It's the inevitable, reproducible, and constant consequence of the chosen therapeutical concept, the concept to choose crystalloids to deal with acute bleeding, to compensate acute bleeding, to maintain cardiac preload in the context of blood losses. I would never say that you cannot maintain blood volume with crystalloids if you are dealing with a bleeding patient, but you have to know the price you're paying for that, and the price is termed initial massive interstitial edema by more than 80% of the infused amount. Type 2 shifting is the inconstant clinical correlate of a breakdown of the endothelial surface layer, an important part of the vascular barrier, due to the surgical trauma, but also due to hypervolemia, and therefore one has to conclude that at least in part, both types of shifting appear avoidable, and it's the decision of the treating physician whether this is important in this individual patient or not. So my conclusion, I think, is quite simple. Do you know where this fluid might have been gone to and why? I'm not sure, but I think I do. We should consider physiology because it might work even in human patients. So to me personally, in the surgical context, in the bleeding patient, I personally would never play with water if the patient is in need of preload. And if you are coming from steady state and going into elective surgery, I personally try to avoid hypervolemia with crystalloids and colloids, and I'm convinced that we and the patient will be very happy with our barrier for a very long perioperative period of time. This is not outcome-based, but this is evidence-based. Thank you.